Without further ado, I will introduce Julie Staves, who is our speaker for today. She's a Transfusion Laboratory Manager at Oxford University Hospital NHS Foundation Trust, and she's also the chair of the National TLM Group, Transfusion Laboratory Managers Group. Over to you, Julie. Thank you.
Thank you, Selma. Hello, everybody. I'm sure some of you know me, some of you probably don't. So I've been in Oxford for a very number of years, like 22 last week. So that shows you there. We've done a lot of work on IT, and I've also chaired the rewrite of the BSH IT guidelines, which hopefully will be published within a couple of months, maybe a little longer. But anyway, so we're not too far off from them either. So today I'm going to talk about advances in transfusion IT, and that's great. Thanks very much. Okay. So what I thought I'd do is just sort of raise a bit of a background. So for me, IT is involved in every transfusion that occurs in the UK today. You know, and in some other countries, but obviously thinking of the UK, which is where we are today. So that could be just from blood collection to the transfusion into the patient. And even if you think, but I work in a hospital that doesn't have any IT, there's a few still out there, it's still involved in the blood collection process and in the testing within NHS BT or in the other blood services if you're not in England. So, you know, it is involved in every transfusion, but I'm not going to try and discuss transfusion IT in the blood services today. Definitely don't know enough about that, but I am going to focus on IT in hospitals. So as a little bit of background, I started working in transfusion in the mid to late 80s, and we did have a LIMS system where I first started working, which was actually in London. And the first IT was brought into transfusion laboratories was LIMS systems, so laboratory information systems. And I think if you look really hard, you can probably find some that were introduced in the very early 80s, maybe even the late 70s. But, you know, quite a long time ago now, you're talking 50 years, which is like quite a long while. So in the last UK TLC survey, which was done in 2017, there were still a small number of laboratories which didn't have LIMS systems. Not many, but there were a few, and they are due to review a survey, I think, from UK TLC coming up. I know Kerry talked to you last month. So in the early 2000s, electronic blood transfusion management systems began to be developed, not least in Oxford, to be honest, and it was something that was looked at to aid transfusion safety, and we'll talk a little bit more about that in a moment. And then if you look a little bit further into slightly later in the 2000s, the National Programme for IT came along, and we were all getting electronic patient records, which are EPR systems, although you know, they were talked about early as 2004 when NP-FIT started, but actually most EPR systems were not put in until 2010. And some places have looked to actually use them to help their IT in transfusion. And I'll talk to you a little bit about order comms from EPR systems, because I think that's an important development that people are possibly not using to the highest facility. So, LIMS systems. I'm going to ask you a question. You can think about it. You can stick it in chat. Do you think you use your LIMS system to the best of its ability? I will answer that for me. No. I think I don't do far off. I think my system's very old. It was installed before I came into Oxford, so you can tell how old it was. But I think we do not make the most of our LIMS system, even in Oxford. We do it a lot, and I think most people are like that. I think it's unlikely that most of you said, yes, I use my LIMS system perfectly. LIMS systems are extremely useful. Obviously, we use them all the time for recording sample testing, issuing units. Traceability is obviously key. Stock management. And I'm sure a lot of you have some basic algorithms in your LIMS is to help ensure that the correct product is issued to the correct patient. But there's quite a lot of problems with LIMS systems. So some of you may have taken part in the SHOT Collaborative, which was done sort of early in 2021, and it's titled SCRIPT, which stands for SHOT Collaborative Reviewing and Transforming IT. And I would have said that some of the data from that survey is actually quite shocking, and I've actually put that in there. And Shruti kindly gave me permission to nick a couple of their points from their website, which was very nice of her. So if you look at some of the IT systems, they're not upgraded. You know, here, look, this last point, some LIMS systems have not been upgraded for over 10 years. And you think what how far IT has come in 10 years, hugely. We all have smartphones, we all use WhatsApp, things that we probably didn't even think about 10, 15 years ago. And most of the problems around why people aren't upgrading limbs is they're not able to do so because of finance, time. It takes a lot of time to do an upgrade on a limb system, and resource. People don't necessarily have the resource to do it. And so that's one of the problems. And this is the other thing that I think is quite scary, is that they asked the question, do you have an IT expert for transfusion in your trust? Yeah, look, the biggest answer was no. 51 out of 89 said no, they didn't have an IT expert for transfusion, which is like nearly 60%. Personally, I think I said no, even though I think if you ask my BMSs, they'd probably say, yeah, we have Julie. So, we will see. So anyway, part of the reason for talking about limbs is that I've noticed that there's an awful lot of trusts and networks out there are implementing or beginning to implement new limb systems. They are, of course, more modern. They're definitely much easier to use. They're so the sort of systems that we use in the old-fashioned ones, I've got Telepath, and that's called a roll and scroll type system. So it's literally, it's just a screen. It's just got typed text on it. They're all now GUI, so they're a lot more like you would expect on an internet, which is great. They're definitely easier to use. But I would say that these systems are usually been implemented as part of a whole pathology network system. And is that the right thing for transfusion? These are things for you to think about. We can discuss them at the end. Is it the right thing for transfusion to be part of a whole pathology system? We are quite a small voice when it comes to pathology because we're quite small in terms of if you look at how many samples we process. I would obviously, as I'm sure a lot of you would say, that we're quite important because, what we do is very different to a lot of the laboratories, but we are quite small in terms of samples. And we also have very different needs and requirements from others. And a lot of project leads don't understand transfusion. I wouldn't say that mine understands transfusion. She's getting used to me and she lets me tell her what I need, which is great. But there are things out there, and I think that there's definitely a question around should transfusion have its standalone IT system, and we can discuss that at the end. So I then wanted to just have a quick overview on electronic blood management systems. So the most common two out there are Blood 360 and BloodTrack. For those of you who know Oxford and know of me, we use BloodTrack, but I haven't, this is not about BloodTrack. This is about the idea of having electronic blood transfusion systems. I think they're absolutely great, and they are designed to be a complete system to track components from the laboratory issue through to the storage in the fridges and then on for safe transfusion to the patient. Some of you may just have fridge elements of these systems. Some of you may have a full system. You can use them for sample labeling at the bedside, which we do in Oxford, and I think is fabulous. It does make samples much easier to much easier to actually read the sample rather than trying to struggle and go, oh, is that an S, is that an E? We've all done it, I'm sure. They do allow electronic control of blood fridges, incubators, which does prevent unauthorized access to those storage units by unauthorized members of staff, which helps you with your BCR form for the MHRA, and it also ensures the correct release of blood to the patients, which is a very safe thing to do. And if you look at some of the SHOT reports every year in SHOT, there are reports where the actual cause of the report was the wrong blood was taken from the blood fridge. So, these systems are definitely in use and definitely have a process. So bedside checking is obviously to confirm that the right unit is given to the right patient. And all of this will have a complete audit trail in whichever system you use, and, allows you to actually, investigate a process. If something goes wrong, follow it along. You can get all sorts of things out of it. So advantages for me, I think these systems are excellent. This is definitely a personal opinion. They do improve compliance with SOPs. As they make the correct thing to do the easiest thing to do. And when we implemented our bedside system throughout the trust, our medical director at the time said we had to make the correct thing to do the easiest thing to do. And I agree with him. I think that's, the right thing to do. They do undoubtedly improve patient safety. They can automate traceability. As a large trust, we probably spend less than half an hour dealing with the odd units that we don't have full traceability on every sort of month. Whereas I'm sure a lot of you spend a lot more time looking at traceability than we do. It does reduce workload for the staff for a whole variety of reasons. The complete audit trail I mentioned, and it does provide evidence to ease incident investigation, which anybody, if they've ever had to do an incident investigation, is by far and away a great thing to do. And I have put here, they do provide a lot of data. You might see that as a bad thing. You might see that as a good thing. I'm a bit of a data queen, so I would say it's a good thing. So these are examples of data. This is my data, so I'm happy to share this data with you. This is actually our transfusion history of number of units transfused in the OUH for just over a year and a bit, 2 years really. So this drop here is the start of the pandemic. This was Christmas when we obviously had another pandemic, and this was Monday. So that's last week's data. And as you see, our data, so this is pre-pandemic. So we were using on average 320 units, and we're now using getting on for 400 on some months. We're averaging over 350, so it's gone up. But this data I produce it every Monday morning. Takes me 10 minutes from our tracking system. And the other things, if you're interested, you can look at them later: platelets, FFP, and cryo. So I just put it in as an example of a graph. It's a nice sort of thing to see. And this is the other thing that I also do every week, is look at what sort of areas are using the blood products. So out of interest, this dark blue line is surgery. And you'll see this dark blue line is on its way up, and it's been on its way up for a year. So that's last January, and this is this week. So you can see like that. And this sort of data is very, very easy to get if you have a full tracking system where they're starting units at the bedside. You can see where they've started the unit, so you can then quickly determine what sort of a patient the patient was and where it should fit in the category. It's an easy quick thing to do, but it allows you, it's very powerful having this sort of data. So disadvantages: it costs a lot of money. I will agree with that. I'm never going to argue that. Implementation is particularly for bedside, when you may have thousands of nurses and doctors, if you want to train them to actually train and keep competent and keep going on the system and show how to use it. It takes time. It's not a quick and easy thing to do. The equipment, the software does need looking after. We've definitely found out that clinical areas are not very good at taking responsibility for kit. We've had them out on the ward since 2005, and clinical areas are really not good at looking after kit. You definitely need to chase them up. Staff do get complacent. I'm not going to pretend that they don't. The bedside check is to act as a second checker, and that the person giving the transfusion is meant to check the unit themselves. But we have found, as I'm sure anybody who's got a system like this do, that they do rely on the IT alone at times, which is not great. But it's better than not having it there at all. And workarounds. It may be more difficult, but staff do find workarounds, and you do need to keep an eye out for workarounds and crack down on them as soon as you find them and deal with them. So anyway, my comments about electronic systems: I think they're definitely worth the work. I'm not going to say they're not work. Advantages far outweigh the disadvantages. They are recommended as the requirements for safe practice by SHOT and other people, but still lots of trust network are finding it very difficult to get money to actually implement these systems and to provide the staff to actually do it. So my discussion point about electronic systems is: do you think that these systems should be centrally funded? And if you think it should be centrally funded, what about those who already implemented? Should they get some money back? Just something for you to think of. I'm now going to just talk about order comms, which is a bit about EPR really. So when I moved to Oxford, I think order comms felt like a goal that I was never going to get to. And it was like, I'd really like it if clinical areas could order blood on a ward, and they didn't have to ring us up because, phone calls are very, very time consuming. And for blood sciences, a lot of them have had order comms for quite a long time, and it's been a priority because of workload. Booking in hundreds of samples, especially from the primary services and GP practices, has been a priority. I'm sure a lot of you have seen it, but I would say that the use in transfusion has been somewhat limited. Some trusts do use AuditComs, but only for their group and safe samples. Not many have gone on to thought about looking at requests for blood components and blood products. Now, when we were putting our EPR system in 2012, I was given the opportunity to look at doing some AuditComs for blood transfusion. I was like, yeah, no, I definitely want to do AuditComs for blood transfusion. They went, okay, just group and saves. I went, no, everything. So we actually do and have done since 2014 order everything online. So I'm going to show you a few screens for you a little bit to think of. This is just in case anybody's never encountered this, it's a good thing to do. So this is so we use Cerner Millennium. It's not an advert by any stretch of the imagination. This is not an advert. So the blood requested, we have a power plan, and so we have multiple power plans. The standard one they use is a red cell power plan for red cells, but they also do the same if they want FFP, if they want albumin, if they want anti-D, and if they want PCC. They're all done online. We get very few phone calls. So you have an order screen. This is the order screen looks like. So the orangey yellowy things are the things that they have to put in, and then it gets signed off and sent through to us in the laboratory. I'm just going to press down because there's a few things of note. We asked them for a diagnostic group, which is basically what clinical specialty is the patient in and why are you giving them a transfusion? And they have to put something in clinical details. And then the other thing that happens, so this is the drop-down list. You're probably not going to see that very well. It's quite a small screen. So, and then the other thing you'll know is that we have a diagnostic group. And so this is, tell us, why do you think this transfusion is warranted? So there is a section that says acute bleeding, because obviously we are going to get some acute blood loss. Now, actually, if they click acute bleeding, it actually just pushes the process and the order through to the laboratory very quickly. Sadly, we don't get a ping if they've clicked acute bleeding, but it is on my wish list of what I would like. The other things that they can pick are, low HB under 70, which is our standard, under 80 if they've got coronary syndrome. Actually, our hematology patients have just dropped to 70, so we've actually just removed that line, but they were under 80 at one point. And then there is another category that allows them to give us some other clinical details if we haven't done it. And you'll also notice the HB is here. So this is what the latest HB was. And so what it does, the system, we've built some algorithms into the system. And what it actually does is, I should have I knew I'd missed something out. I'm going to apologise. I meant to put up a screen that showed you an alert that comes up. So if they order blood and they say that the patient's HB is under 70 and the HB itself is, say, 80, they actually get a little message that says to them, hey, you're ordering blood outside of your own guidelines. Are you sure you want to do that? And they can say, no, okay, I won't bother doing that. I'll cancel that request, which is great, saving blood products. Or what they can do is say, no, I want that blood. And if they say they want that blood, it actually makes them tell us why they want the blood and why they think that their need is greater than the guidelines. We didn't want to put a hard block on everything because we felt that it would be quite, there may be a reason why somebody wanted blood that we didn't understand and you couldn't get from just some numbers and some very basic information. So they are allowed to continue. But what we do have is we do have a registrar who looks at all those alerts that have been overridden I think they do it every day or every couple of days, and they actually ring them up and have a discussion with them if they don't agree with it, to just provide some teaching. And it works really well, and we've reduced our blood product usage a lot. I'll show you some details. So a word of caution. If you can go...
before we go on, there's a couple of questions in the chat related to what was presented. If we could get to those first. So the first one is, are you using BloodTrack to generate breakdown of red cell component usage per speciality?
Yes, I am.
Okay, that's a quick one. And the second one is, how is the ordering controlled for EPR? Is it only a certain group allowed?
Yeah, it is. So what we've done is we've limited it to medical staff and to nurses who've got prescription rights. So we've actually linked our blood ordering. So any nurse can order a group and save. Nurses cannot order blood products unless they are a prescribing nurse. I'll come to that question who's just put up there later in a minute. But Yeah, no, so any nurse who has got prescribing rights can order blood, because we've actually linked the order for the blood to our prescription, which I didn't bother covering in this talk. But if anybody wants any more details, very happy to show them some information around that. Should I carry on?
We've got one more question, but I think
sure.
we'll do that later. How are lab staff led to a new request?
Oh, let me show. I'll show you because it's in my talk.
Okay.
I'll come to that.
Go ahead.
So
that's all for now. Thank you.
Yeah, sure. Thanks. So a word of caution. If you're going to go for order comms, which is great and, you know, works really, really well, you do need to agree a process for urgent requests. So because obviously what you don't want is somebody putting on an urgent request onto the system that you don't know about and that you don't see for a little while, and that might cause a problem. So what we've done in the OUH is we don't put our MHPs and massive hemorrhage activations onto EPR. They're actually only able to activate an MHP by phone, and that way we know that the request has been dealt with. And I think that's me being a bit, I don't want to miss one. I don't want to cause a patient a problem. So we do still have phones for major hemorrhages. Anything that's urgent but not a major hemorrhage, they do place it in the order comms, and then we ask them to phone to tell us that it's urgent. And we find that actually the message at the beginning was they didn't really get that very much, but actually as time's gone on, they're very good at ringing us if it's urgent. And as my thought has always been, if they can't be bothered to phone me, it's not that urgent. So there is obviously, if you're going to put order comes in, quite a lot of changes in the lab. There is a reduction in work. I'm not going to claim there isn't, particularly in requesting. It's far, far easier. It's wonderful. There is a reduction in errors made at requesting. Which I guess you might find quite supplying. You do get better information. The patient demographics come over exactly what's in your EPR, and if you're using an electronic bedside system like me, you really want them to match, because that patient wristband comes from your EPR. So actually they link together really nicely. You do get a lot better clinical information. The number of phone calls we have in the laboratory is far, far less. I have visitors and they're always going, you don't get very many phone calls. And we used to have 2 people answering the phones constantly. In, say, 2010, we had 2 people answering the phones constantly in my lab. We were very busy. Now we have 1 person on the phones, and actually, you know, the phone doesn't go that much. We get a lot less phone calls. I think it dropped by about 80%, the number of phone calls, which might surprise you. And my goal is a paperless laboratory. I'm not quite there yet, but it's getting there. And with a new IT system, that's my goal. So you might think paperless. Okay. So the one thing we don't have on our order comms is I do not get a request card. And some of you might be really surprised that we don't have a request card. So we work from the IT system thing. But so when I first said to my senior members of staff, oh, when we go to order comms, we're not going to have a request card. And they were like, oh my God, we need a request card. And I said, no, we don't. Right. So what I got them to do was I got them to write down everything that they used a request card for in the lab from start to finish. And we then wrote down an alternative way of doing it that didn't need a request card. And actually now, if you ask them, they wouldn't want request cards, because they're a bit of a pain, and they're paper, and what do you do with them, and you've got to scan them. It just creates work. So things that we were doing, we were checking them against the sample when they first come in, but we actually check it against the order on the system now. When making a worksheet, yeah, we used to use that. Well, actually, we now check against the sample, which is actually what you should have been doing anyway. And knowing what you've got outstanding work, that you need to order blood products and things like that, we've got a whiteboard in the laboratory. We've got a far number of different processes. None of them were insurmountable. We don't miss request cards. We've redesigned our processes, and yeah, you need to get your if you were somebody like me, you need to get your laboratory staff on board. And I know they wouldn't go back, because I was talking to them about it the other day. Not that I was planning to. So these are, I'm not going to go through that. So just a little bit of data. You see, it's quite old data because we've been doing order comms since 2014. So what I did was I did an audit of 100 paper request cards and 100 electronic requests. And you can see on here that, actually we were not getting consultants only 22% of the time. I suspect you're similar. We were not getting NHS numbers that often, even though we asked for it on our forms. Location, when you're a multi-sited trust like us, actually having the location of where the patient is in case you need to send it to another site is really quite important. Diagnosis was poor. Special requirements, we very rarely got any special requirements. We always get them now. And how to get hold of the person? Nah, we didn't get that. It is 80 something, but we're now at 100% because I've actually put that in my order line of how do I get hold of you if I need to ask you a question. And that's really quite important. So you can see why I think it's an advantage, I'm sure. So what's been good? It's quicker. Requesting's quicker. There's been a lot of typos. Different location sets for different sites works really well because I've got 3 laboratories. So the site in Banbury, which is at the Horton, has a different set for issuing products, and it auto requests from where the patient is. And seeing outstanding work is very quick and easy. So I've got. Oh no, it's the next slide. So other advantages: we know what's coming in before the sample gets to us. We can see orders for phenotype units far earlier than when we were getting the samples in. So we can order them in advance. We're getting them up. Allows us to spot when we need to order units. We get HLA match platelet requests quite a lot quicker because they don't bother to phone us, even though they're meant to. Not having to scan request cards, and we have a lot less confidential waste, which is important to get rid of. So this is what. This is what comes through to the laboratory. I've obviously blanked out the patient names. So we get an outstanding order list that comes through to the laboratory that we check. So we started checking it every hour. It is meant to refresh every 5 minutes. It's not great at refreshing because of the age of my system. So what we do is 24 hours a day, we say that we check the outstanding cross-match platelets, FFP and cryo requests, to see what's outstanding and deal with them at that point in time. So we've made our turnaround time for a routine cross match 2 hours, which actually, even if they put it in 1 minute after we've actually checked the list, we will get to it and issue it in that time. And actually our compliance with our turnaround time is extremely good. And anything urgent, they'll phone through to us and we just pick them up and do them at that point. So other problems, we do have some clinical staff don't bother putting in the correct date and time that products are required. This is particularly a problem with platelets. They press return and then wonder why when they want the platelet the following day, it's been returned to stock. So we've done a bit of education with, it was particularly bad on haematology doing that. So we've done some education with that. Because we've linked prescribing and ordering together, we do sometimes get a doctor who will order 1 unit of blood and prescribe 3, and then the nurses are going, where's the other 2? So but they're minor things and they're minuscule numbers. So
Julie, we've got a couple more questions.
Yeah, sure.
In the chat, if that's okay. Just give you a break as well while we read out some of the questions. So one of the first questions is, are your diagnostic criteria broken down by surgeries and procedures?
They are. They're actually already in the old BSH guidelines. They're actually an appendix, and they will be in the new guidelines. Which I saw there was a question about the new guidelines. I'll talk about that at the end. But
okay.
They are available if anybody wants them. They're not secretive, and they were actually developed as a bit of a collaborative. They're not just Oxford. They started in Newcastle. Actually, we added to them, and the NBTC has also looked at them and sort of approves them. We did add a COVID one a couple of years ago, which I'm sure you can understand why.
We've got a question about some of the data that you shared about your lab earlier. It says you use 350 units of red cells. Is this daily or weekly?
That's weekly. Yeah, no, I'm not quite that busy at daily.
A lot of blood for a day, isn't it?
Yeah.
Okay, so the next question we have is, are your samples labelled using the BloodTrack PDA system or the Cerner labeling system?
They are labelled using TX, so the BloodTrack PDA system. I looked at the Cerner system for like addressing graphs printed out on demand, and we refused to use it because they were all printed out at the nurse's station, and we felt they were too much of a risk. Although they were on demand, you could print them early, and you could print them out with millions of other ones, and we just felt the risk wasn't suitable for that. There is a system coming in Cerner called Careware Connect, which is similar to TX. We will let it settle in for the other laboratories and view how many wrong blood in tubes they get before we even remotely consider changing.
And the second part to that question as well, which is how is PPI carried out if no request card when taking samples?
Oh well, they do it against the patient's wristbands and against the request on the EPR system, because the EPR system is what the nurses use all the time. And we check the order, so the order comes through into the lab and shows us all the patient demographics, and we check that what's printed on our sample matches what's on the demographics on the order. It's just a different place to check.
Sure. So the last question that we've got is regarding the new guidelines, but you said you'll speak about that later.
No, I can talk about it now. So they are currently, I submitted them to BJ Heem and they were too long. So I've been revamping them and putting some more things in an appendix to make them shorter for publication, but leaving all the key points in for hospital staff. So the things that are going into appendix are things like the procurement processes and things like that. So I need to resubmit hopefully by the end of this week, if not the beginning of next, and they're open. And fingers crossed they'll be published later in the summer. But if anybody wants to know, I'm talking about IT guidelines at IBMS, and I'm also talking about them at BG blood group serology in Nottingham in April. So if anybody's going to any of them, I am talking about them. If anybody's got a burning question, email me. I can tell you what's in there.
We've just had one more question in the chat regarding downtime and business continuity. So do you have an option to get a paper form during downtime?
Yeah, we do. So all the wards have, because all the laboratories are now paperless request forms. So what they actually have, every ward has a locked drawer which has paper request forms in it for downtime. Yeah, and we've had to use it occasionally. We had some Cerner downtime, oh God, it was way before Christmas. And yeah, they did have to get them out and use them. But, we standardly, if we get a paper request form, if we're not on downtime, we actually do reject it.
Okay, that is great. That's all the questions I've got for now. Thank you.
Okay, so I'm not that far off the end. You'll be pleased to know. I've probably talked enough. But anyway, so you do need to get some clinical engagement if you're going to move to order comms. And I'm not saying it's easy, but it's persevere, and it's actually very rewarding. So we actually rolled our blood product ordering out with our medicines management when they were doing it in Cerner. So they did some training along with that at the same time, which actually worked really well. And if anybody's going through that, and you could do that, it works really well. We did initially, all we did was encourage people to order online, but we then, after about 7 or 8 months, we said, right, okay, we give you a date, it's 3 months ahead, that on this day everything will be, apart from very urgent requests and major hemorrhages, will need to be ordered online. And we were very tough. We had one clinical area, which was gynae, which might make some people laugh, who up to that point didn't want to use order comms and wouldn't do it. And we kept warning them that, like, as close as it got to the day where they were going to get their samples rejected and their orders rejected, we told them every time. The TP spent a lot of time over there making sure everybody knew what to do. And on the day when we were going to reject samples, if they didn't come from order comms, they'd sent us a sample by 10 o'clock in the morning, and it was on a request form. And I personally rejected it and rang them up and told them I'd rejected it. At which point they went into a little tiz because they'd had a sample rejected, and they said, oh, what can we do? What can we do? And I said, you can do what we told you to do, which is order it electronically. And it only took one sample to be rejected to convert them that actually order comms was actually essential to do. But it just shows you that until you actually are tough, they will not do it. So I would recommend being tough. I know it's a bit hard, and I know some of my staff think I'm very harsh, but you actually do have to be tough, because otherwise you just make exceptions all the time and nobody ends up using the systems. So so for that. So this is graphs up to 2019. What I didn't do was I didn't put in our photographs at 2020 and 21 for obvious reasons due to EPR, because due to the COVID pandemic, because obviously the impact on the EPR system on that is very hard to, you can't really say anything about it. So this blue line at the top is our red cell usage. So you see our red cell usage back in 2012 was about 28,000 units of red cells a year. And in 2019, it was 17,500. So that's quite a drop. And we saved about 5 million in 4.5 years. And yeah, we're very popular in the trust, because although the system cost us a lot of money and we put a lot of effort in, we did make them that saving. And it's perseverance and other things too, but it's an important thing to do. And I just thought I'd show you that, because it did really have an impact. And we have defaulted it so that it's 1 unit is the default, and you can change it, but a lot of them now default at 1 unit, which is really good for PBM, which is what I would want to say. And I think that is me, apart from what do we want to talk about. So I put, we can talk about anything you want to talk about in this field. I can elaborate more if people would like me to, but the discussion points I sort of picked up on were: should a transfusion laboratory have a standalone LIMS and not be connected to the rest of pathology? There's pros and cons for that. Should electronic blood transfusion management systems be funded centrally? I can show you some figures, Malcolm. Do you really need a paper request form for transfusion samples? Is ordering components and products electronically appropriate? Would you want to do it? Would you think it's a good idea? And does transfusion as a service need better IT support? I can answer the last one in one very simple answer of yes, but I'm very happy to discuss it. And that was it from me. So.
There are a few questions, Julie. If you want me to read them, and then we can do the discussion.
Yeah, let's do it.
So is there a way this can be modified to suit other laboratory units, or is it only peculiar to blood transfusion?
Oh, so all our laboratories in Oxford have order comms in through our EPR system. So yeah, no, it's not a pure transfusion system. We've just put, it was just one part, and everybody built their own system. Everybody worked together, and a lot of it is very similar. So all the stuff around date and time of samples and things like that are all in for everybody. I think the only lab that doesn't use order comms exclusively is Selma, and that's actually because they get a lot of them from theatre, and the theatre module in Cerner has only just been rolled out, so they're expecting to be a bit more serious coming forward.
And then somebody's asking, they're not aware of the Cerner system and whether you can explain how samples are labelled at the bedside.
Oh yeah, no, it may be easier if yeah, the problem is if I play that video, it won't have any sound on it. We've got some videos about how we label samples at the bedside. Hang on a second. I haven't got a patient wristband. So what we do is, I'm just going to pick this up. I'm just going to show this. So
we can't quite see it because you blurred your background.
Yeah, let me so you're now all going to see my very messy office, so you can all laugh. So I'm just going to unblur my background. Just to make it a little easier. No, it didn't unblur. That was interesting. Okay. Oh, come on, computer. Oh, that doesn't think it's blurred, but it is. Hang on.
Never mind. So should we just try?
Maybe I've just put a different background on. No, because I can't see it because it's blurring everybody.
Yeah, we can see that.
This is the PDA that we use. It's an old style PDA. We are about to change systems. So what you do is in order to identify your staff, you set this going. You say you want to take a sample. You scan your ID badge on, which all our ID badges in the trust have a barcode on. So we work by barcode. You scan your ID badge, you scan the patient's wristband. Unfortunately, I don't have a patient wristband with me, so I can't show you one, but they've got a QR barcode on with all the patient demographics in it, which includes the patient's surname, first name, date of birth, hospital number in it, and then it displays it on the screen. So you do some PPID with the patient, and you do this after you've actually bled the sample. You do PPID with the patient to, you know, if they're conscious, to actually check that you've got the right patient details brought up, because I guess there's a risk they could have a wrong wristband on them, and then you do a little checklist that you can build in, and everybody's checklist is probably similar but not identical, I guess, and then it allows you to then print off a sticky label at the bedside, because you take a printer with you, which I'm going to put the PDA down and not pick up a printer because I don't know where it's gone. But the little printers are, they're the little tiny ones that if anybody's been, oh no, I can find it. Here it is. So this is what the printer looks like. And you've got that with you at the bedside, and they're connected by wireless, and you can then just print out the patient's sticker that you stick on the bottle, and that comes directly through to the laboratory.
Great, thank you. James, did you want to ask your question? Do you want to come in now before we carry on?
Thanks. Hi, Julie. It's James.
Hi, James.
Hello. I fully agree with you that transfusion needs specialist IT support from someone with both transfusion knowledge and IT knowledge. Where do we find these people? They're a very rare breed.
They are a very rare breed. I will totally agree with you that they're a very rare breed. I think that's something that we've raised at NBTC, and you know, I flagged with Kerry at UKTLC as well. I'm just not sure that there is anything out there to actually train us. I think what we need is some actual training for transfusion laboratory staff to actually get a bit more knowledgeable about IT. You know, I've worked with IT. I wouldn't say I'm an IT expert, but I've done IT ever since I've been here. Yeah. And you know, I'm self-taught. I'll be honest, I'm self-taught with a little bit of expertise that I've picked up as I've gone along. And you know, I think I could do it better, and I'm sure other people do. I think it's something that we as a community need to try and address. Maybe it's a subject to take higher. Maybe I'll go back to NBTC with it.
I definitely think laboratories should invest in the workforce for IT training.
I'm hoping SHOT might help. Yeah. I'm hoping SHOT might help, because you know the recognition of it has come by SHOT. Yeah.
Brilliant. Thanks, Julie.
Great. Anas, did you want to come in as well?
I was just going to follow up on James's point about lab staff also doing IT. So I'm a biomedical scientist by background. I've worked in hematology and transfusion. I'm currently on secondment in our LIMS project. We're upgrading our LIMS across the pathology network. But after this, I hope that I'll have the opportunity to work in the lab, and also because I've got that knowledge of working in the LIMS system, be able to input, oh, we need this change. You know, I know how we can do that. I can log a ticket quickly, and I can tell them exactly what needs to be done. Maybe within the labs, we need to support our staff who are interested in such roles to, you know, take up that training, to be able to, you know, provide the extra support for the pathology IT team. They're not full-time members of the pathology IT team, but they can recognize where changes need to be made, and they can highlight those for the IT team, and then they can make those changes.
I'd agree. Totally. I would totally support you in that. I think that's a very sensible way forward. And I'm hoping as people put new limbs in, that's what they actually do, because they are going to end up with some experts that, you know, particularly on the limbs. And I think then what we need to do is think about how we actually address the other bits. So, you know, so I've actually had some EPR training, and in fact, I'm going to get a little bit more, so that if we need any changes, that we can get them, you know, done. I can do them in house. But, you know, I guess a lot of other people wouldn't have that capacity, whereas I think, you know, we've got that need that we actually need to think about how we do it. I think the biggest problem is the lack of staffing across transfusion generally. At the National Lab Managers Group, the last time we met in January, the big topic of conversation is, how do you recruit a good band 6? And I think we're all in the same boat. I don't think anybody's, you know, got massive excess of staffing.
Yeah, so there's a question, somebody said that they label the sample using iPads. Do we still have to handwrite and sign, or is signing enough?
Well, we personally don't get our lab staff, our phlebotomy, whoever does the phlebotomy, to actually sign the request for the sample as well. There is an identification on the label that we put on the bottle printed at the bedside, so we take that as a signature. I guess you could say there's a slight risk that somebody could use somebody else's request card, ID badge, because that's where it comes from. But obviously that's a disciplinary offence if they use somebody else's ID badge.
Okay, great. And then what is your impact? I'm assuming what's your impact on wastage?
Right, okay, so our wastage on around EPR ordering has actually been very positive. So our wastage is currently running at about 1.4% for red cells. And I think what that's doing, I think the reason, so it used to run at about 2.5, just over. And I think the reason it's actually dropped is that actually what's happening is people are ordering one at a time. Because of that, order one because you only need one has actually really impacted on that, and I think that's what's helping us actually get our wastage down. We're doing other stuff as too, but I think that helps.
Right, great. What percentage of samples do you reject, and what are your most frequent reasons for rejection?
So the number of samples that we reject is absolutely tiny. Reject due to, so it totals less than 1% of our samples. I think the last time I checked it, it was 0.72 or something like that. So the most common reason that we reject it is actually that they don't bother putting an EPR request into the system, and they just send a TX sample and expect us to process it. So that's probably about 90% of the reasons that we reject a sample. And we put publicity out saying if you do this, we don't process them. The other little bits are there wasn't enough in a tube. You know, we get occasionally, so on our system at the bedside, you can use a training mode, which allows you to actually do testing and train people without, and it prints out a label that just says test patient, and very occasionally a nurse will print a real patient's sample and put on test patient, and then we reject it. But it's probably one a month of them. It's tiny numbers.
Okay, there is a question. When you have a planned shared specimen reception for, say, a new pathology network, how would you ensure that transfusion samples, for example, transfusion labeled, are checked to correct compliance standard when booking in? I personally don't have, well, I do have shared reception, but we actually book transfusion samples in transfusion partially because reception is manically busy, and partially due to the fact that, like you, I would also have worries to check that were they actually checking it properly. So we actually do check in transfusion ourselves, but yeah, I think you would need to make sure that that actually, you know, you probably just need to audit them regularly and check that they are checking it properly. And I'm hoping that most people are still checking samples as they get loaded onto analyzers. We definitely do, and I know all the part in our S4 network definitely do. And I was going to say, if you're getting mistakes noticed at that point, that's, you know, you then need to go back to your reception and say, actually, you're having a problem. So there's quite a few more questions. I'm not sure whether we'll manage to have all of them. And then somebody raised their hand. Let's have a look. Chimdinma, did you want to ask your question?
Question. I just wanted to address one of the things Julie mentioned. She said she's not sure if anyone has enough band 6 people to handle all of the jobs available to do. And I think if that's the problem, so why don't we improve on, look at it from the education angle, try to improve on the level of IT and lab management modules that are inculcated in the basic and master's program for biomedical sciences. I think that would help in trying to shore up the workforce to ensure that enough IT compliance is achieved in blood transfusion.
I'd agree. I think it'll take a little while to get through to the courses that people are doing, but I agree. I am a little concerned that I know the MSc, which is now run out of UE, is has got some IT stuff in it, not least because I've talked on it. But it's it's going to take a little bit of while for some of that to get through to the MSc courses, and some of the courses like the BBTS special certificate and things like that. I flagged at that point that we need to actually encourage increased engagement with that. I think it'll come. I just think it's I think we're at the start of a process, and I think we recognise it now a bit more than we did previously, and I'm hoping that we'll get there in the end, maybe before I retire.
Hopefully. Well, I think that's the best way to handle it. Addressing it from
I would agree with you.
By the time people are graduating, they are already ready to begin to step into the system the way they are expected to.
I'd agree.
There's a question. Have you made any updates to the system to manage transgender patients?
No. Oh God, transgender patients are a whole can of worms, which is going to be addressed by the National Transfusion Committee, not least because I flagged it once more at the exec working group literally 3 weeks ago. So at the moment, our Cerner system only records whatever one gender. They are at some point going to change it to put in like gender at birth, sex at birth, and gender that you want to be called at. At which point, we're also building that into our new IT system, and it will work on the electronic system as well, because you can add different sexes for that, genders for that. I think the problem is at the minute there is not a huge amount of guidance out there nationally for the entire NHS, and it's something that needs to be addressed totally, and it needs to be there so that transfusion limb systems use gender at birth. I don't know, most people, if somebody wants to call themselves the gender that they weren't born with, I don't really, it doesn't bother me one jot, whatever they feel comfortable with. I think from my point of view, what I'm worried about is, are you planning to, would at some point you be able to have a child? And if you would, I want to treat you as if you were female, regardless of what you want to be called, not to insult you in any way, but actually to protect any future pregnancy and child that you may have. And I think, we need to be very conscious of that, but I'm not sure there's a total answer yet.
Fair enough. So we have about 5 more minutes left. I'm just one more question. How many wrong blood in tubes do you have annually with this system in place?
Oh, 1 or 2.
Oh, great.
And usually it's somebody has decided to label the sample away from the patient bedside. Or they've printed off a label from a wristband that isn't on the patient or something like that. It's somebody not following the process properly.
Great. Danny, do we have time for a few more questions? Or?
Yeah, I think perhaps we could do 2 more questions.
And then the questions that don't get answered, we're happy to email them to Julie. And
please do.
Yeah, hopefully she'll be able to answer them. How does the group and screen request work for GPs? Is this paperless?
Okay, so we don't routinely do group and saves, mainly from our GP practices. Antenatal samples do come still with a request card, but when we're getting the new IT system, I'm planning on losing that as well. But that would be through ICE requesting rather than EPR. Our GPs don't currently use our EPR system.
Great. So with the discontinuation of paper requests, how do you confirm that the sample acceptance checks and patient history checks are performed prior to a sample being processed?
Well, just by checking. So the request on the screen is just exactly the same as the request on the paper system. You've got all the same information. You just need to check up against it. So it's just, you've just got to get used to the fact that you haven't got a bit of paper to check against, that you're checking it on a screen. And I guess for some people it's very difficult to actually check against the screen initially. And I guess we all struggled. I'm sure at the beginning we didn't actually save much time in requesting, because we were all been so careful to check what was on the screen matched our samples very closely. But actually, once you get used to doing it, it's actually as easy, if not easier.
Thanks very much. Danny, did you want to come in at this point?
Yes, thank you very much. So firstly, I'm just looking at the comments, Julie, and I think I speak on behalf of everybody today. Thank you very much for joining us.
You're welcome.
And sharing some of your expertise and insights. I think it's been a really interesting and pertinent chat today. Lots of discussion and lots of questions too. And I think I don't know if you can see the comments now, but lots of thank yous coming through just now. So really well received presentation. Thank you very much. And secondly, thank you to Selma and Anna for managing those questions throughout the afternoon. And thank you to the 150 of you attendees who have joined us today to listen to Julie speak and to get involved with the discussion. It's been a really good session.